I know it's going to be hard. Ignore the bottom. I'll just stand here if I have to. Don't look at me. Just look up above. All right, so you drove into a metal fence. All right? Obvious external chest injury with bleeding coming closer to the patient. EMS can hear a sucking sound. What does that sound like?
Sucking. Sounds like sucking.
Okay, good. The amazing thing with a lot of these, so instead of going back and forth pulling these up, Google this stuff. Like, there's videos galore out there.
Google sucking?
No. Chest wound / sucking is probably the safest way. Let's try that. Okay? You definitely don't want to start at the beginning because then autofill automatically puts stuff in there because you're not on LCC Wi-Fi. Okay? And it's always the funny disclaimer at work. Everybody's on the department Wi-Fi, and they're like, "Hey, you should look this up." And then they're like, "Well, maybe you should disconnect from the city Wi-Fi first." It's like, whoa. As the officer, hey guys, we should not be looking up this if we have to disconnect anything, right? Back to sucking chest wounds. Okay. So you got somebody impaled. Are they impaled? No, not impaled.
Drove into.
Okay, so you got this person, 21-year-old, drove into a metal fence. They're on a motorcycle. Oh man, Noah, jeez. Boom. This is what we got. Now you had a bad day. Can you guys see that?
No.
There it is.
That is a metal post impalement. It was impaled.
Was impaled.
They hit it, boom, and then out they go. Okay? And as this person breathes, you're hearing. What's your first thought?
Chest wound.
I quit. Right? My first thought is like, oh geez, you picked a bad day. I'm on the medic. This is not. You could have picked a better paramedic, right? Is that what I'm thinking? No, not really. But so yeah, merge it. 6
Yes.
6.
So,
First thing in your head is.
Trauma activation.
ABCs.
So
How
you're
do you
walking
fix
out. So you're
that?
not even 2 ABCs yet. You're like, well, I already know this is a trauma activation criteria, right? So what does that do to me now?
10
I
minutes.
gotta do
10
everything
minutes.
fast.
Like, hold on. Okay, here we go. Let's go. No, hold on. Here we go. Right. So just think of it that way. Like,
Bang in reserve.
yeah, you take a little nitro boost and boom. All right, we have 10 minutes to be here, there, done, out, good. Right? Piece of cake. And you gotta get them on the backboard at the same time. It's just you and your partner. Good luck. Right? So, how are we dealing with this?
How concerned are we for spine management versus that sucking chest wound? I mean, the backboard is going to be a great tool to move the person, but with a sucking chest wound in 10 minutes.
So with this situation, your concern with C-spine is pretty much that. Because why?
Airway comes first.
Yeah.
This person is basically, they're dead, they just don't know it yet, right? And so it's your job to keep them from knowing that they're dead,
Yeah.
right? So this person, we're not gonna fix this person. Surgeon's the only person who's gonna fix this person. ER doc, not gonna fix this person, right? ER doc's gonna think they can, but it's not even close, right? So this is a surgeon thing that they need to fix this person. But it's our job to keep the person alive long enough to get them to it. So we have to do everything that we can to stabilize this kind of situation, right? So going back to our March mnemonic, right? Massive hemorrhage. Is this massively bleeding?
Most likely.
How
Not
can
from
we
what
control
we can
this? We
see.
can't, right? Like unless we got like clamps and stuff like that, there's really not a whole lot we can do for the bleeding aspect of this, right? Are we gonna pack the chest wall? No. We don't have enough gauze and pack to do this, right?
Is that pole still in there?
No, so the pole is out, right? So with this picture here and what we hear, right? So we're gonna completely eliminate the mentation. Let's see, did we have a mentation on this one? Let's go back to boom. Okay, we can move down now. Oh, is alert, in pain, and severe shortness of breath. Those are our vitals. Oh, geez. GCS of 15. Oh, geez. What's that mean?
Wait, he knows what's going on.
This person knows exactly what's going on. Well, this is bad. This is bad, right?
For now, he knows what's going on.
Left is greater than right?
Yep.
It's better than.
Some of this right
Diminished,
side's
so diminished on the
diminished.
right, because that was the right side, right? And then look at the injury, which, look at the injury, general impression.
I know.
Do we have a piece of bandage that big, or is that?
Put my hand on it.
Stuck in the hole?
So we're gonna eliminate the hand because we don't just bury our hand into somebody's chest wound,
Hand
right?
on it.
Right?
Right.
Right.
Okay. So the idea behind this is you have a sucking chest wound, and if we don't stop the sucking chest wound, what's going to occur?
More tension.
Tension, hemo, pneumo?
So think about what's happening. Why is it sucking? Why is it a sucking chest wound?
Because the
what's it doing?
diaphragm's pulling down
Pressure.
and
It's
pulling.
sucking the air from the outside, right? So they're breathing here, they're breathing here. Is this a direct route into the lungs?
No,
So is this a direct route where?
into
To
the
the
thoracic
cavity.
cavity.
Part of it may go into, so obviously there's a hole between the lungs and the cavity, right? Like somewhere,
A fistula.
and here we go again. We're gonna just disregard Mark.
Put it,
Oh, I was just walking around.
No, it just got real happy.
you might want to start further down on the board. Just saying.
We got a transition, I mean, it happened. Okay, so second chest wound, so we want to keep that air. There's a hole somewhere in that lung that air, there's an open passage, right? Not a fistula, right? So what we need to do is we need to stop that to ensure that the only air that's going in and out is here, right? So how do we do that?
Cover that hole.
We cover it, right? But do we want to allow air to escape?
Yeah.
Yes, we want the air to be able to go out. We do not want the air to come in. Because if we don't let air out, we run the risks of, because you have this hole somewhere, which you don't know, maybe there's other holes in there, that if you just keep putting air in and don't let it go out, the only way for it to come out is this way, and you can overpressurize, right? So you can blow the chest up. So what we want to do is we want to allow the air to have an escape route, right? So that's where it comes into our occlusive dressing. And the idea behind the occlusive dressing, right? So they're like a Vaseline gauze occlusive dressing. The idea behind it is we're going to tape it on 3 sides, okay? And when I say tape, is tape going to stick to that?
No.
So what we got to do is we got to put this massive bandage, okay? You're overlapping big time, okay? You're going to probably want to use your 3-inch tape, as wide as you can get, and put your bandage on there. So this is sealed from here all the way around now, okay? So what's going to happen is it's going to create a little burp valve right here. And it's going to allow this bottom portion of the occlusive dressing to let air escape out. So this is where we tape our 3 sides and allow that to breathe, okay? If we have multiple points, like an entrance and an exit, do we want multiple bleeder valves? We want 1 bleeder valve, right? So we put a patch, occlusive dressing on the back, because, so if we have one on the front and one on the back, which one would we put the bleeder on?
The front.
Front.
So we
Why?
don't launch it.
The top.
A, you can monitor it. B, you put somebody laying on an occlusive dressing on the back, it's just gonna seal it off, right? So you always wanna make sure you have something on the interior side. So, let's say you only have a sucking thoracic posterior chest wound. It's only on the back. This is on the back.
We're gonna put it on his back and we're gonna lay him on his other
Him on his good side and.
There goes
side.
your C-spine.
Can you just put like something?
I thought C-spine was already out.
Absolutely. No, you're right.
Alright, so in this situation, you're gonna put the person on the backboard as normal, right? And this is where your badass assessment skills are coming back in, okay? You're gonna continue to monitor. And if you start to develop trapped air, which is gonna cause what?
Hypo.
Hinge pneumothorax. Are we gonna needle decompress that?
No.
No, what are we gonna do?
Burp it
Air
out.
out.
We're gonna burp the air, right? So it's on the back. So boom, hey, we gotta roll this person over, we're gonna burp it, right? And by burping it, all we're doing, so on that back, this time we did not, because it's only a single wound, we only take the 3, we're gonna just go ahead and take the pressure off. You're probably gonna get this type of sound or visualization. You're gonna see the little air pressure relief from that site. Make sense?
Mhm.
Same thing on the chest. If for some reason you're noticing there's a tension pneumothorax developing, and you got your three-way valve, three-way thing taped off there, it's okay to pop that thing up for a second, try and get it to burp, right? Because the idea is you have the hole, you have the needle decompression hole already there, self-made, self-provided, right? All you gotta do is open it up to allow it to breathe.
Don't need to
Okay.
vent if it's already vented, right?
So, all right, so we're gonna throw our occlusive dressing on there.
It's like a house fire. You don't need to vent a house fire when it's already vented.
For stopping the bleeding as well?
Yeah, you don't care about the bleeding at this point, because it's gonna just continue to ooze, and there's not a lot that you can do for that type of bleeding, right? That's where the clamps, massive bleeding, they're gonna have to do skin grafts, they're gonna have to do all kinds of stuff, to end up stabilizing that hole, all right? So your job is basically to keep the lung oxygenation going, and if it's small enough that you can control the bleeding, great. But if you have a hole like that, if you control the bleeding on the exterior, what's gonna happen? It's gonna bleed into the chest wall cavity, right? So it's gonna create the hemothorax. This person's gonna end up with a chest tube anyways.
So you're gonna manage that hypovolemic state with just providing fluids?
Yeah, yeah.
We're
Just
gonna-
making sure that, so our first initial blood pressure, 90/62, heart rate of 130, we're not happy with that, right?
Yeah.
So, person's not dead yet, but take a look at this next blood pressure.
Ah.
Yeah.
Oh, damn it.
Are we
Had a
considering
really bad day.
TXA?
Yep.
How, at what point, obviously he's shit out of luck at this point, but with those blood pressures going down, heart rates going up, I'm already thinking to tube him and knock him out.
Oh,
Can you tube somebody that has that much damage to a lung?
absolutely.
Okay.
Yeah, absolutely. No, this person, without a doubt, like, as I walk up, I see this hole in this person's chest.
Yeah.
I see that they got a GCS of 15. I'm like, that's weird. Oh, that sucks. Do I want to be a GCS of 15 with a hole in my chest? No. I'm thinking, boom. Like, immediately I'm thinking, this person is not going to survive for very long with this chest. So what I'm going to do is I'm going to be ahead of the game. I'm going to have my respirations under control so that as this person's basically like dying in front of me, I'm not being like, okay, we're going to get ready to start compressions. Wait, no, are we doing compressions? What are we doing? Like, am I going to do my airway? So I'm going to be super aggressive and I'm going to take over the airway very, very early with this patient. Like probably in the back of the ambulance, let's get our IVs, get the occlusive dressing on,
And I wonder if, like,
and get that.
you are listening to the radio traffic of this particular call, I'm assuming assumption sucks, but you're probably gonna start hearing stuff like massive chest wound, post in chest or
No,
something like that.
nope, you're gonna get an unknown injury motorcycle accident. Because that's how our dispatch is awesome.
Well, yeah, so I'm just thinking that I would almost be prepping all of my intubation stuff, all my drugs before I even got on scene.
So, you gotta get to the scene.
Yeah.
If we get disregarded on 90% of things, like, you cannot prepare on the way to a call. Like, I would say 10% of the time, you would be prepared. Like, if you prepared with every single call, 90% of the time, you're like, whoa, I just wasted an entire RSI kit on medication because this person, is set and trapped, unconscious, and it's a no patient. Patient refusal. All right, so you really can't you can be thinking, like, I've double gloved before I've gotten out of the rig, thinking, okay, I look at this call and I'm like, yep, and here comes another set of gloves, right? So I double glove anytime that is something that I know that I'm gonna be getting my hands dirty, because getting a second pair of gloves on when you're wet and sweaty is not ideal, right? And so every once in a while, that is my preparation for a serious call, is just basically double gloving it, right? Because you really can't, until you see what you have, you would just, unless you got volunteers that are there on scene giving you that information. You can't take an average bystander's word for stuff. Now, if I got volunteers on scene, then I'm just like, okay, this is my plan, this is what we're gonna do, but you're not gonna stop, pull over so somebody can get in the back and start drawing stuff up. But you can talk with your partner and be like, okay, as soon as we get there, don't even get out, you go jump in the back of the rig, grab the RSI drugs, get those ready, this is what we're gonna do. I'm gonna C-spine them, or throw them on the board, and I'm gonna get them to the rig. We're gonna do that before we roll. We're gonna RSI them, tubes in, and we're going, right? That you can do if you have information coming from the volunteers on scene. But when it comes to dispatch, you just, 10% of the time, they're accurate. Actually, I think it's 12 is the actual number. So yeah, legit numbers, legit numbers.
You said you get them on the backboard, get them back in the back of your rig, and then apply the inclusive dressing. Are you doing that on scene?
The inclusive, yeah. So I'm throwing the
That's your
inclusive.
immediate life threat, you're
Mhm.
dressing
Yep.
on scene. How do you do it?
Yeah, so basically I'm gonna walk up, I'm gonna see this person, I'm gonna hear that. And the first thing I'm gonna do is, before I even do any sort of assessment, I'm directing somebody to get the inclusive dressing, because unlike for you guys where everything's instantaneous, to be like, hey, they got an inclusive dressing on, and da-da-da-da-da, and it's like, no, hold on. Like, you gotta get it. You can find the inclusive dressing, dig it out, rip it open, find the tape that's gonna stick to this person. So it's gonna take a good 2 minutes to get the inclusive dressing off, all right? So you have to be like recognizing and calling the shots as the lead paramedic. Be like, yep, hey, I need you to go grab inclusive dressing. As soon as you're there, you put your hand there so that you start. I mean, that's a huge, I don't know if you're gonna be able to use your hand on that one. Probably gonna have to use 4 or 5 inclusive dressings to actually cover this one, right? And so if, in that situation, what I'm gonna do, the way I'm gonna put the inclusive dressing on, let's say I have this giant hole. Okay, so say I have this big hole here, right? And because that's a pretty huge hole. Our inclusive dressings are like this big, right? So I'm just gonna kind of patchwork this together. Try and get as much of them on, and then I'm running the tape straight across. Just like that. Now I'm gonna leave, and as I have these down here, I'm gonna run it so that basically I keep that bottom portion of it still open and able to flap. Does that make sense? You're gonna have to think outside the box on some of these. Like, it's not I have a bullet hole and my perfect occlusive dressing fits perfectly over it. It's already been predetermined that that's what it is. And so it's that type of approach that you're gonna have to kind of patchwork stuff together. All right? So this person's dying, right? Everybody agree?
Yep.
O2 IV monitor, take over their airway, manage it, give them some fluids, chest wounds covered up, got all that. Intubate.
Wait, what is that? The trachea is about the size of the patient's 5th finger?
Five,
Usually in pediatrics, that's what you use.
5th finger, is it the pinky or is it the thumb?
Pinky.
So I would not commit that to memory.
I just saw that as you're going, I'm like, really?
Goes in and out, tachycardia, hypovolemia.
Wait, who is that?
Patience.